Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss-Studientelegramms, Marcus at Home welcomes Dr. David Jayne in Cambridge, United Kingdom, with whom we would like to discuss ANCA-associated vasculitis. Dr. Jayne, it's an honor and a privilege for us to have you tonight. Thanks for being our guest.
Thank you very much for the invitation.
Dr. Jayne is Professor of Clinical Autoimmunity, University of Cambridge, and Director of the Vasculitis and Lupus Service at Edinburgh Hospital. He is President of the European Vasculitis Society and contributed to many national and international treatment recommendations and guidelines, including the EULA-ERA ANCA vasculitis recommendations and recently the KDIGO 2021 guidelines. Many studies have been conducted by Dr. Jayne and his team across the globe, actually, and they are the backbone of today's evidence-based treatment in ANCA vasculitis. These comprise, but are not limited to, Paxivas, Mykic, Mepax, Clear, Rituximab, Cyclops, and many others. And I'm particularly honored to have two collaborators of Dr. Jayne today as co-moderators, namely Kirsten Groot from Offenbach, who is first author of Cyclops, and Andreas Kronbichler, who presently works in Dr. Jayne's team in Cambridge. My name is Gunnar Heine. I'm a nephrologist in Frankfurt.
David, we are very happy to have you here. And we have not just a nephrology community, but probably also internists and probably also students. So would we probably step a little bit back, and could you probably comment on how we do the ANCA testing nowadays that has undergone a change? We have been grown up with the immunofluorescence tests. That was the golden standard, and that has changed in recent years. Could you probably tell us how that came along and why we did that?
So the main value of ANCA testing is in the diagnosis of vasculitis, and the indication for requesting a test is when you're faced with a clinical scenario where you suspect vasculitis as being part of the diagnosis. There have from the origins of ANCA testing always been fluorescent testing and solid phase testing, and over the years the solid phase assays became specific to the targets proteinase 3 and myeloperoxidase, and then the performance of those solid phase assays have progressively improved. We've never been able to standardize the fluorescence testing, and even though it's now been present since the late 1980s, there's never been universal standardization of fluorescence testing. And there has been a debate as to the sensitivity and specificity of these individual assays. And in a European survey around 5 years ago, the antigen-specific assays, that's the proteinase 3 and myeloperoxidase assays, performed very much better than the indirect immunofluorescence assays in terms of their sensitivity and specificity for the diagnosis of vasculitis. So this led to a European consensus statement that the ANCA assay now should comprise the PR3 and NPO ANCA ELISAs, or solid phase assays, however they're performed. We still, though, recommend that the indirect immunofluorescence assay is available on request if the solid phase assays are negative and the physician is still concerned that they may have missed a positive ANCA case. But it's important to remember that these tests have limitations, and we do make the diagnosis of ANCA-associated vasculitis in some cases even when the ANCA test is negative, and that's a very important concept to be aware of. It does put more responsibility, though, on, for example, gaining a tissue diagnosis or on the confidence of the clinician with the clinical presentation they're faced with.
Yes, thank you very much, David. I think this is important to say that the immunofluorescence is not out, and it's a concept that we can recur to if we are left with an uncertain result in the ELISA test. And other than vasculitides, this is a different story. We still use the immunofluorescence more often than for the vasculitis diagnosis. Is there any other autoantibody that you would consider to be important to order when you suspect ANCA-associated vasculitis?
Yes, I think whether you're coming from a rheumatology or a nephrology perspective, we're trained to request a panel of immunological tests. Certainly, if you're, for example, have a patient with nephritis, then you'll want to exclude anti-glomerular basement membrane disease. You'll want to do an anti-nuclear antibody and tests for other lupus-associated antibodies. We would routinely test for anticardiolipin antibodies, a lupus anticoagulant. Rarely, there is an overlap with antiphospholipid syndrome, and they can have a particularly severe phenotype. You might also routinely check complement levels. Although complement levels are normal, classically in ANCA vasculitis, with the focus on complement inhibition, there's now increased interest in complement levels. But of course, mainly we're looking for immune complex disorders, which might be associated with low complement levels. And we'd perform immunoglobulin profiles to try and exclude paraproteins, as you might have associated with a cryoglobulinemia, for example. So I think it's important that although you're suspecting a vasculitis, your diagnostic range, if you like, remained quite broad. Yeah. We're used to diagnosing single diseases, but we do often see overlaps.
Yeah, absolutely. That's great. Thank you very much. You have already alluded to the dilemma with complement. We have termed these vasculitides post-immune vasculitides years back, and now complement creeps up and is a very prominent feature and therapeutic target. What is your view on, should we, in the diagnostic frame, should we focus more on complement, on probably subspecies of complement products, or in the histology look more closely for complement products?
I think in terms of circulating products, I don't think there's anything that can be moved to the clinic easily. We know that certain studies looking, for example, at C5 split products such as C5a or the terminal attack complex C5b through 9 are in general higher, but the spread is really wide, and the same, for example, factor B. So I think the clinical utility of circulating complement fragments hasn't been demonstrated. I think talking about the kidney, I think it's a really interesting debate that's going on at the moment. You and I have been aware that patients, a third of patients do have immunoglobulin complement deposition in the kidney.
Absolutely.
And we know that this may be important prognostically. It may sometimes throw up the possibility of other diagnoses co-occurring. For example, IgA nephropathy can co-occur with vasculitis. But there's also a recent observation from the Mayo Clinic where they have reported on ANCA-negative patients with post-immune rapidly progressive nephritis, and they've highlighted some electron-dense subendothelial lesions, which they've sort of inferred might be contain complement or complement fragments, suggesting that there are different types of pathogenesis that may be more or less important in different scenarios, and there might almost be an overlap with C3 nephropathy type pathology in some cases.
Probably just one last question concerning ANCA. We know that it's very important for building the diagnosis of ANCA-associated vasculitis. What is the value in the course of the vasculitis of monitoring ANCA titers?
So many, many years ago, Jan Willem Cohen de Wet did a randomized controlled trial where he based intensification of treatment, which in those days was cyclophosphamide, on the basis of an ANCA test, which in fact was the fluorescent test. And he had a Lancet publication and a positive trial. But in general, the utility of ANCA in monitoring disease activity has been controversial. And I think the simplest thing to say is that any sort of ongoing treatment, whether it's steroids, immunosuppressives, will tend to dissociate ANCA from disease activity. So if you're trying to evaluate the role of ANCA in patients, say, on long-term azathioprine and steroids, it's very difficult to show a strong association of change. Now we use rituximab as maintenance, and then often just stop it, and a patient is on nothing. The whole situation has become a little bit clearer. And if you're on no ongoing therapy, then occurrence of a positive ANCA or the clear rise in ANCA is quite strongly correlated with relapse. There was a nice survey recently from Onno Teng from Leiden in the Netherlands, where he, particularly focusing on PR3, showed the high specificity of a rise in PR3 for relapse after rituximab. The problem was it's just not sufficiently sensitive, and about 50% of the relapses were occurring without a change in ANCA. So you have to understand what the value of the tool is that you're using. And yes, we measure ANCA, and if it changes, we take notice, but you could be caught out without the ANCA changing.
Would you make a difference between MPO and PR3 ANCA in that respect, especially concerning the treatment with rituximab? We know that PR3 ANCA is probably more informative concerning
Yes.
the future relapse.
I think there's sort of two questions there. One is the MPO ANCA as a biomarker as useful as the PR3?
Yeah, exactly.
And the other is, are the differences in treatment response to rituximab between PR3 and MPO ANCA patients? I think in general, the MPO ANCA is as good a biomarker as PR3. I think the same sort of rules apply. But in terms of your second question, I think this is fascinating. Now, the RAVE trial, which was the 2010 randomized trial of cyclophosphamide rituximab, was predominantly PR3. And they published a post hoc analysis saying, actually, if you just pulled the PR3 patients out, there was clear superiority for rituximab over cyclophosphamide.
Yeah.
The subtext of that is, well, maybe the MPO patients didn't do that well. And actually, there weren't very many, but if you look in the supplementary appendices to these publications, the MPO patients didn't seem to do as well.
Yeah.
And the numbers were small, but in Rituximab, which was the trial that we did in Europe, we had many more, higher proportion of MPO ANCA patients. Yeah. And although they all seem to do well in terms of remission, the MPO ones all relapsed, So you weren't getting that difference in relapse risk between PR3 and MPO that we think from other areas. So I think the jury is out, but my own personal experience is that rituximab is slightly less effective in MPO ANCA disease than PR3 ANCA disease.
Yeah, that's what I would think as well. We probably come back to that later. I think I hand on to Gunnar for the induction treatment.
We focus on those patients who are most interesting to us. So those patients with a really severely affected kidneys with ANCA-associated vasculitis. Your KDIGO guidelines give us two options at equal levels, so rituximab and cyclophosphamide. So if a patient comes to your hospital, how do you choose one of these two options? Cost is an issue, and you already alluded to the distinction between the two different types of ANCA-associated vasculitis.
So I think the factors you're going to take into account are the age and frailty of the patient, the clinical serologic phenotype, and the severity of the renal dysfunction. And there is an absolute lack of evidence using rituximab without cyclophosphamide in patients with advanced kidney injury, so serum creatinine above 350 or 400 micromoles per liter. And these patients were not studied in RAVE, and in Rituximab, we combined low-dose cyclophosphamide with rituximab. So in general, if we have a patient presenting with advanced kidney injury, we like using cyclophosphamide. But the advantage of rituximab is that you can stop the cyclophosphamide after 2 or 3 pulses, so 2 or 3 grams, and you can reliably taper the steroid to 0 by about 4 months. And you probably, but this is not yet proven, get a higher quality or more patients into a higher quality remission with the combination. So provided a patient is reasonably robust, in Cambridge, at the moment, we tend to give combination therapy. That's not exactly what KDIGO says because it's not evidence-based outside rituximab. Now, for the patient presenting with less severe renal disease, or for the very elderly, frail patient, I don't want to put a particular number, but we're talking about over 80, over 85, then we would tend to go with rituximab alone and with steroids, and thus avoid the use of cyclophosphamide. But we do that with the knowledge that we have cyclophosphamide available and that we can introduce rapidly if we're not getting the sort of response we want to get. And with the very elderly patients, we may give them 500 milligrams of rituximab on 2 occasions, some IV steroid, and then try and run the oral steroids really quite low, because we know in that subgroup the infective morbidity is so high. So I think the difficult area, and I don't think the KDIGO was particularly useful in guiding people what to do, is in those patients presenting with acute kidney dysfunction.
So this brings us to our second option, and you have done the 2 major studies in this field, namely plasmapheresis. So you did the MEPEX study, you did the even larger PAXIVAS study. The first study did suggest some benefit, at least during the first months. PAXIVAS was actually neutral. So what are your current approaches for these patients again? When do you still use plasmapheresis, or don't you use it at all?
Yeah. So, with clinical trials, you always have to try to understand the subtext and the politics behind how the trial was designed and why it was designed. And essentially, MEPEX was designed by a group of plasma exchange enthusiasts, and it was weighted to trying to get a positive result. So it just studied the most severe, creatinine over 500, and it just focused on kidney survival and produced a positive result. What was interesting, if you look at MEPEX, is we subgrouped patients as to whether they were oliguric dialysis requiring or they were still producing reasonable volumes of urine. And we did not see a strong signal for plasma exchange in the latter group. So the signal for plasma exchange was in the oliguric dialysis requiring, i.e. the most severe, because they would have the highest end-stage kidney disease risk. So then you have this result, you get the European recommendation saying use plasma exchange in this subgroup, and you get the North American continent essentially not believing us. And they don't like plasma exchange outside 1 or 2 centers, and don't like European data as a prejudice sometimes. So as we were all working together, the question of, we should examine plasma exchange together came up. And part of the designing PAXIVAS was actually setting a much higher bar on what was efficacy. And that was one of, the compromises of the North American partnership, was that the primary outcome was the composite of death or end-stage kidney disease. Yet we knew from MEPEX, or we thought we knew from MEPEX, there was no effect on death, full stop. But we thought, if we ran the trial for 5 years, those getting end-stage kidney disease must have a higher mortality risk. So, it would probably come out like that. And of course, what happened was we showed a hazard ratio of around 0.85, whereas we needed a hazard ratio of around 0.65 to get statistical significance. And that's what we reported in the New England Journal. We reported it exactly in the way the trial was designed. Now that we've done post-hoc analysis and meta-analysis, if you pull the deaths away, and there was no effect on death at all of plasma exchange in PAXIVAS, the hazard ratio for end-stage kidney disease starts dropping. So if you pull death away, the hazard ratio comes down below 0.8 to 0.75. And then if you start looking at end-stage kidney disease at a year in subgroups, you're getting down to around the hazard ratio that we thought we could detect. And essentially the meta-analysis, putting the PAXIVAS data together with all the previous studies that have been done for the endpoint of end-stage kidney disease a year, is reasonably convincing of benefit for plasma exchange. And then the debate is the benefit enough to warrant a recommendation or not? And because the benefit was detectable at all levels of renal function in the meta-analysis, but it's only in those most severe patients where the benefit is big enough to be useful clinically. And the number of patients needed to treat to save a year of dialysis is around 7, or between 6 and 7 for a serum creatinine above 500. And on balance, that's felt to justify a recommendation. As soon as you drop below that creatinine 500 threshold, the number needed to treat shoots up, and therefore the utility, if you like, becomes less. So the recommendation, and I was not allowed to be part of the recommendations group, this is a British Medical Journal Rapid Recommendations group, have come out with a recommendation for above 500, and they say a consideration for 300 to 500. And in practice, it's those patients who are going off in front of your eyes, but haven't quite got to 500 that you might want to consider it.
And there's the subgroup of patients with lung bleeding who also appear to benefit, particularly, if I got it right.
So the eligibility for Pexivas was a GFR less than 50 mils a minute or lung hemorrhage. And we defined lung hemorrhage, and it's the first time it's been defined in a clinical trial. And essentially, you had to have radiological infiltrates plus another parameter, such as a fall in hemoglobin or oxygenation or whatever. That definition appeared to work, and we had 190 patients with lung hemorrhage in Pexivas. We then subdivided them into those who are hypoxic on room air and those who weren't, and there were around 60 per group, hypoxic on room air. And I just saw a couple of days ago, because it's going to be presented as an abstract at the Dublin meeting, the analysis of plasma exchange on diffuse lung hemorrhage. And essentially, the hazard ratio for plasma exchange is around 0.45 for death for lung hemorrhage. But the numbers are too small to give a p-value. And essentially, there were about 6 deaths in the plasma exchange group versus 10 in the non-plasma exchange group. The curves are quite pretty. I mean, they separate immediately and stay separate when you look at the survival curves. And also of interest is there was a difference in the non-severe group. It's small, but there was a similar hazard ratio difference of about 0.45 for the non-severe group, although they generally do well. So I think, the debate is going to rumble on. Those who believe in plasma exchange for lung hemorrhage will point to this beautiful graph showing the separation of the curves, and they will say, well, this is convincing evidence. And those who don't believe plasma exchange for lung hemorrhage will say there was no statistical significance, the numbers were too small. There you go.
So another study on induction treatment, again from you, is the MyKick, which I found very fascinating, particularly for frail patients in whom we might be somewhat reluctant to go with either rituximab or cyclophosphamide, because you showed that actually mycophenolic acid may also give quite convincing data for induction treatment. Do you use that in clinical practice regularly in these patients?
The short answer is no, we don't. We set this trial up at a time when rituximab was not widely used, and we were very keen for an alternative, particularly in younger patients, to cyclophosphamide. So that's the background. There have been 2 or 3 other small studies. So there's been a Dutch study looking at relapsing patients randomized between mycophenolate and cyclophosphamide, and there have been 2 studies from Asia where MPO-ANCA sort of predominates. And there have been a number of meta-analyses, and they basically all say that if you look at 6 months, you don't see a big difference between response rates. But what was convincing with my side was the excess of relapses that we saw in the mycophenolate group when we followed people on for longer. And that's certainly been my clinical experience, is that you can give mycophenolate and steroids, you can get a reasonably good response, but as you start dropping the steroids down to any sort of maintenance level, most patients then relapse. So I'm not saying don't sort of use it, and if anything, the evidence for MPO is stronger than for PR3, but I do feel that there's a high risk of relapse as you reduce the steroids. So we hardly ever use it anymore as induction therapy. And the story is a little bit like, and Kirsten will be very familiar with this because she was intimately involved with the methotrexate story, where we did a study suggesting methotrexate was as good as cyclophosphamide, but actually by the time you take the steroids down, you then see a big difference.
Yeah, That's true. David, may I just intervene a little bit with the old people and using slightly reduced rituximab scheme, which sounds sensible. We have such a scheme for old people with cyclophosphamide. Louis published that. And we have no data from a trial using rituximab on a reduced base in old people. In terms of the pandemic, I personally tend to use more cyclophosphamide because I think in case the patient contracts COVID, then the cyclophosphamide is probably quicker out of the body than the rituximab, which has a very prolonged effect. What do you think about that? Do you still use rituximab in the same way at the moment?
No, I mean, I think you're right. I think in the COVID era, we think twice now, or three times before using rituximab. But also in the COVID era, we have other considerations like trying to keep the patient away from the hospital and trying to deliver a simpler treatment that's going to be as undemanding as possible, because certainly our primary care system in the UK has been has been struggling with the pandemic.
Yeah.
And if anything, we've been using more of the combination, so 2 and 2, rituximab, cyclophosphamide, because that's just 2 visits, usually the first one they're in hospital anyway, and then they're done. We've even gone back to trying to use oral cyclophosphamide in some of the elderly patients, if we can be confident that the patient's family practitioner will do the blood counts. Because it will keep them away from the hospital. And yes, we would use very low dose.
That is a very interesting point, because in Germany, that would be an off-label use, which strictly this is the case. And then the health system would not reimburse it. They say, you are doing off-label use, you can't do that. That's very tricky. I try to do the same, give just 2 pulses of rituximab at 1 gram per pulse. To save them 2 more visits in the hospital. I absolutely agree. But you can get into trouble with being off-label, which is stupid, but this is a situation that is different in Germany.
But the point about rituximab is, well, there are several points, but there have been now large rheumatology registries which have compared the different DMARDs used in rheumatology in terms of risk of hospitalization with COVID. Yeah. And in general, most DMARDs used in rheumatology are neutral, but rituximab definitely to be very not neutral.
I know this paper, yeah.
And is saying 4 or 5 times more likely to be hospitalized. So there's that problem, and then of course there's the problem of the vaccine response, which is a big issue.
So I would have one last question on induction, and then I switch the mic back to Kirsten. One general aspect of KDIGO guidelines last year was that steroid dosage are lower than recommended in the past. And this is particularly true for lupus and for ANCA-associated vasculitis. So what is your current standard for steroids in Cambridge at the time being?
So we would use the Pexavas reduced dose regimen for patients presenting with a more aggressive. One of the problems that we have is the nomenclature that we use in terms of how severe patients are. And this is touched on in the KDIGO guidelines. But for a patient presenting with kidney injury, we would use IV steroids, usually 1.5 grams total. In Pexavas, we permitted between 1 gram and 3 grams. And then we would use oral steroids, approximately 60 milligrams a day for a week, and then halved to 30 milligrams the next week, and then tumbled down to 5 milligrams, and just follows the published, and that's actually in the table is in the KDIGO guidelines. For those patients who are the frail elderly, and for those patients with less severe presentations, then we often use below 30 milligrams a day of steroid. Might give a week of 30, and then we go down. Now, in the Rituximab trial, which we may go on to when we talk about maintenance, we induced patients with relapsing disease with rituximab and with steroid. And there was a lot of debate amongst the investigators as to how much steroid should you give a patient with relapsing disease who is having an acute flare. And so we said, well, you can give them either 1 mg per kilo per day or 0.5 mg per kilo today, but tell us in advance and we'll stratify accordingly. And Rona Smith wrote up the results of this, and essentially there was absolutely no difference any way you cut it in terms of outcome, whether they were bad patients, whether they were good patients, whether they had 1 or whether they had 0.5. So it's not randomized data, but it's reasonable quality data. And I think for relapsing patients, it argues we should be starting at 0.5.
Then probably let's come to maintenance of remission treatment, which takes up much more time from the patient's lifespan. So it's very important to choose the right drug for the right patient. Now we have seen there's a significant benefit of rituximab over azathioprine as a maintenance of remission agent. Would you recommend that everyone got rituximab as a maintenance treatment?
I think if you'd asked me that question 3 years ago, the answer would have been yes. But I think life has become more complicated.
I agree.
Just to give a little bit of background, as you know, we all used oral immunosuppressives with or without steroids as remission maintenance therapy. And the debate really was whether you needed the steroid or not, which immunosuppressive was better than which, and they're probably all roughly the same, and how long should you go on for? Those were the sort of the debates. Along comes rituximab in the early 2000s. It seems to be working well. And then from 2007, in fact, when Rachel Jones joined our group in Cambridge, she pushed using rituximab maintenance. And actually, in retrospect, it was almost erroneous because she thought, or we thought, that this is what they were doing in rheumatoid arthritis, giving 500 or a gram every 6 months. It actually wasn't, but we thought it was. So we said, well, let's do the same in vasculitis. And then for about 10 years or more, we've given a gram every 6 months for 2 years. And it just transformed our outpatient clinic. It made it much simpler. Patients were off steroids. While they were receiving the rituximab, they were reliably controlled. And we were all very happy. And then, of course, Mainritzen comes out. That is the French trial, as you say, clearly showed after cyclophosphamide induction, rituximab was superior to azathioprine. And then we did the ritazoram trial, which showed that after rituximab induction in a slightly higher risk patient group, or with relapsing disease, rituximab was better than azathioprine. So the data is there. What we're living with now, though, are the problems associated with rituximab. And interestingly, it's not money anymore because rituximab is now generic. The price has come right down. So it's not money. The problems we have are those of COVID that we've already discussed, and those of secondary immunodeficiency. And we're just completing a registry study that Roche actually paid for as part of their post-marketing requirement to look at all of our adverse events on rituximab going back to 2003. And all I can say is they're alarmingly high when you look at all of the infective morbidity these patients have had, and actually higher than any control group that we can look at with standard treatment. So rituximab is not necessarily a safe treatment. And I think that's really what we're struggling with now. We've clearly demonstrated efficacy, but we have increasing data on safety. And Joanna Tu wrote a paper last year. 40% of our cohort developed an IgG below 6, and increasing numbers below 3, all then requiring immunoglobulin replacement because they have recurrent infection. And that's a real worry. And I have young patients in their 20s for whom I've changed their GPA diagnosis to a diagnosis of a chronic secondary immunodeficiency.
Well, that's an important point. Do you substitute IVIG below a certain threshold, even though there's no infection?
No.
Just to prevent?
No. And again,
would that be an option?
It's what they do with kids, certainly with children, where people tend to be much more permissive about use of immunoglobulin. I'm not sure what it's like in Germany, but in UK, we have severe difficulties in accessing immunoglobulin unless, and so we actually produced some guidelines we published in about 2 years ago, which was basically saying, as the IgG levels are falling, you should refer patients to immunology for a full B-cell immunodeficiency workup. The subtext of that is that the immunologists are much better placed to advise on prophylactic antibiotics and which patients should then benefit from immunoglobulins. So that's what we do. When the IgG gets down to, say, 4 or below 4, heading to 3, we refer to immunology, let them do the workup and take the responsibility for whether or not to start prevention.
That's a good thing. We don't have the same type of institution. For us, it would be more a problem. But then the other side of the coin is, when do you give azathioprine today? Are you using it more now?
So
in view of these data?
So Bernard Helmick is leading the 2022 update of the EULAR recommendations for ANCA-associated vasculitis. And he sent me a draft of the recommendations, and they did not include the use of oral immunosuppressants as maintenance. So I wrote back to him and I said, what about using azathioprine or methotrexate maintenance, especially in the current era? So I think this is going to be a discussion point, but clearly some people think the data is so strong that we should not be talking about using azathioprine anymore. But as Andreas knows in Cambridge, for those patients we induce just straightforwardly with cyclophosphamide, and we still do some, we tend to go to azathioprine or methotrexate or mycophenolate first. And then, yes, if they relapse, then we'll move them across to rituximab. So what I think is the much harder question is what to do in the rituximab-induced patient, because my own view is that azathioprine is less effective in that setting than after the cyclophosphamide-induced patient.
Yeah, I agree. I'm doing the same thing. Like, I think that brings us a little bit to the risk stratification point. Who is at risk of relapse? And that probably drives one or the other treatment. Would you like to comment on risk predictors of relapse in ANCA-associated vasculitis?
Yeah, so I mean, I think the ballpark figure is 50% 5 years, and studies are a little bit one way or the other way for a composite of GPA and MPA. So that's roughly 10% a year will relapse, whether or not they have sort of relapse prevention therapy. And certainly a diagnosis of GPA, younger patients, those with better preserved renal function, those with ear, nose, and throat disease, and those with persisting ANCA at 6 months, all seem to have higher relapse risks. But the other thing that are important when we're discussing this is the patient's education and adherence to therapy and advice, and tolerability of therapy, and also what the consequences of relapse may be. And if you have a patient who you think is pretty chaotic and is not going to have appropriate monitoring, then rituximab is probably the great solution, because they've had it and you can forget about it. But if you have a patient who is going to be very attentive, maybe do their own urine dipstick testing, you're going to be much more relaxed about allowing the relapse risk to rise, because that they're going to be on the phone saying things are changing. And so I think that's an area of clinical management that often doesn't receive enough attention, which I think is very important.
That's true. That's a very good point. I think it's a shared decision anyway, it should be. So in this respect, yes, we have to incorporate the patient into the decision. Do you use corticosteroids at all during the maintenance phase, let's say stratified for either rituximab or azathioprine maintenance treatment?
So in terms of rituximab, I think you should always try to have the patient off steroid by 4 months or 4 to 5 months, and you can usually achieve that, and that should absolutely be the goal. For steroids, no, we would say I'm sorry, azathioprine or methotrexate, we would continue the steroid out to a year, ideally at 5 milligrams a day, and then at a year, make the decision. But, Mike Walsh has done a couple of literature reviews which imply that if you stop steroids, you drive up the relapse risk. Yeah. And I think that's probably correct. And we did a trial, Remain, where we compared 2 years to 4 years of azathioprine, and we actually kept the steroid going at 5 milligrams with azathioprine. So it was actually the combination of azathioprine and low-dose steroid.
Do you routinely control for cardiovascular risk factors? You as a nephrologist probably do more than rheumatologists. Do you see there's a difference?
I think this is a very understudied area.
Yeah.
And we've got increasingly good evidence of the rates of myocardial infarction, stroke, thromboembolic disease in our patient population. Yet we don't have any very good strategies as to how to reduce these. So I have nothing very positive or strong to say, except we know there's a problem. I think the sort of interventions that we're interested in early is probably anticoagulation, or at least an antithrombotic strategy, maybe for the first 3 to 6 months, because that's when the risk of cardiovascular and thromboembolic events are highest. Longer term, then yes, we control blood pressure. We're nephrologists, we're used to controlling blood pressure. We're completely unsure as to whether statins help or not. And of course, now we have the SGLT2 inhibitors with no good data in vasculitis, but data outside vasculitis suggesting that might be a good thing. But I don't think we're close enough to being able to recommend them yet.
No, I don't think we can do that. But would you see a place for a trial using SGLT2 inhibitors as an add-on in whatever induction or maintenance treatment of vasculitis?
Very much so, and I think it would be a very feasible trial.
Yeah.
I think we have a lot of these prevalent patients out there. I think it would need to be reasonably long.
Yeah.
You're looking at, when you're looking at a prevalent population, your rates of progressive kidney disease, your cardiovascular event rates are going to be relatively low. So it's going to be reasonably large scale, but I see it as a doable study.
Yeah.
And I think, often with studies, the interest is what is the added value of doing the study over and above the specific question you're asking. Yeah. And I think it would focus people's minds a little bit more on the whole area of cardiovascular.
Absolutely. Disease. Away from the pure immunologic side of the problem. I absolutely agree. I would be on board. Okay, I think I hand over to Andreas.
Yeah, thank you, Kirsten. And David probably wondered already what I'm doing on the call. But now moving on to the more modern treatment approaches. And of course, we need to talk about complement inhibition. And given the approval of Avacopan in Germany, Austria, and hopefully soon in the UK, who would be your preferred patient to treat with Avacopan instead of steroids?
So the dilemma we have with Avacopan is that the eligibility for the phase 3 trial Advocate was fairly broad, and therefore the label, both in Europe and in North America, is fairly broad. It essentially is a diagnosis of GPA and MPA, active disease, and they've introduced the word severe without defining what severe means. And that covers new patients, relapsing patients, so it covers essentially most patients with active disease. And then we have a very expensive drug, which our healthcare systems are going to want us to ration. And I think that's putting responsibility on us to tell them, well, actually, we don't want to use it in everybody. We want to use it in these narrow, well-defined subgroups, which aren't going to bankrupt the healthcare system. And I see 3 subgroups that I would focus on. The first one is the easiest one. It's those patients for whom steroid avoidance is particularly beneficial. So, for example, diabetics, patients with a history of psychosis, patients with established osteoporotic bone disease. So I think patients for whom steroid avoidance or minimization is particularly important is the first group. I think the second group actually are those presenting with severe kidney disease, because we saw better recovery of renal function. Now, where you cut the bar, whether you say below 45 GFR or below 30 GFR, is going to be arbitrary. But if you just look at those patients in Advocate coming in with a GFR between 15 and 30, then they had an 8.5 milliliter better recovery of GFR, which I think is going to directly translate to major health benefits. So I think the more severe GFR group, and then the third group, and the weakness of the third group is they were not studied within the Advocate trial, are those refractory patients. You know, those are the patients sitting in front of you in the clinic in whom you've given rituximab, you've given cyclophosphamide, you've given a lot of steroids, they still have an elevated creatinine, they still had an active urine, and you haven't got good control of their disease. And we all have these, they're not many, but we all have these patients. So the refractory group, I mean, I would tighten the definition of what I meant by refractory, but would be the sort of refractory group. Those are the three groups I would argue.
So one point of criticism about that Advocate was, of course, that it followed a bit a rave trial approach, and the rituximab treated patients were basically without immunosuppression once the steroids were withdrawn. So in clinical practice, would you just go and give these patients, for instance, azathioprine or rituximab as maintenance therapy if they have been allocated to rituximab?
So this, you know, I think the reason why Advocate was designed was to try to demonstrate that Avacopan had a therapeutic benefit. And so we took advantage of the window between maintenance rituximab becoming more widespread and it not being licensed yet, not to use it within the trial. And something like 70% were rituximab induced and had nothing after induction. And in fact, most of the benefit of Avacopan was seen because of the difference of relapse rate between month 6 and month 12, because those given rituximab are starting to relapse. Now, you're absolutely right, that does not adequately reflect current practice, but it does demonstrate that Avacopan has an efficacy against placebo, which is why it was so important. What we're going to do in practice, I think, if you're going to use an expensive drug like Avacopan, is you're going to want to try and use it on its own. And if you're going to need a second drug, then I think that reduces the value of a very expensive drug a lot if you're going to have to give a second drug. One of the problems of my position is I'm now being contacted by physicians in America saying, well, I've been using your drug and it's rubbish. You know, it's not working. What do I do now? So we'll see.
Yeah, I think if we want to reduce the costs, we may stop at 6 months and then just add in rituximab. But I mean, this is just a discussion. I think we need to find some data here.
I think in a patient that has achieved a high quality remission, the urine is clear, the creatinine is stabilized, I think that's a very reasonable thing to do. Yeah.
So can you just give us a perspective about side effects, especially, I mean, in nephrology, we have been used to eculizumab, and what's the main difference here?
So the worry with eculizumab is meningococcal infection, and there's been no case of meningococcal infection in any patient who's received a C5a specific drug, whether it's Avacopan or one of the other C5a drugs in development. So there's not those concerns around blockade of C5b pathway. I think it's fair to say right now, we don't have a safety concern with Avacopan, but the total number of patients exposed remains really quite small, and the total length of exposure is maximum 12 months. Now, the FDA made an awful lot about hepatotoxicity, and they made an awful lot of noise about creatine phosphokinase elevations. The latter were all pretty mild, asymptomatic, and self-limiting, so it's hard to know what that means. And the problem with the hepatotoxicity is patients were all on multiple other drugs. You know, was it the Septrin or Bactrim? Was it the azathioprine? And the pharmacist or pharmacologist who was present at the FDA advisory board actually said there is no clear evidence of hepatotoxicity with Avacopan, but it is in the label that you need to monitor liver function, because we did have several episodes of liver dysfunction. But then you see that, yeah, as I say, with these drugs. So I'm not saying it's a great, completely 100% safe drug, but what I am saying is that the safety has been looked at in obsessive detail, and there isn't a strong signal at the moment for something to be concerned about.
So do you know when we can expect long-term data from Advocate?
No, and you know, one of the really frustrating things about being an advisor to industry, it's a little bit like being an advisor to government. You know, they'll use you while they like you, and then they throw you away. When, I'm not saying they throw me away, but they will hear what they want to hear, but they won't hear what they don't want to hear. And, you know, right from the beginning of the development pathway, we said, do the 12-month trial and then do a 2-year extension study and examine the long-term safety and the long-term efficacy, or can you stop the drug? And they said, sure, sure, sure. And of course they didn't do it. And of course that's really come back to bite them, because now they're being laden with post-marketing requirements to do exactly that. And they're currently, you know, the FDA have given them a 5-year post-marketing trial to do, you know, big trial, 5 years. So it's going to be very expensive. But unfortunately, we're not going to get the results for like a decade. You know? So it's not a very practical value. And the other problem is that we as academics can't go and do that study ourselves because the drug's too expensive. So it's a sort of example, I think, of dysfunctionality between drug regulators and drug industry, because the FDA or EMA could have easily said, if you want us to agree a pathway to getting your drug licensed, we will license it at 12 months, but you have to produce more data, you know, give you a provisional license depending on further data, and they didn't do that.
So one of the points of discussions is, of course, the price. Can you say something about the price in the States charged by chemocentrics and the price in the EU, UK by Vifor?
So it's $150,000 a year in the States. But what you have to understand is that's not necessarily what people pay, but that is a very expensive drug in the US. To be honest, the UK price has not been published. There have been some prices knocked around, which are very, very much less than that. But often what happens in the UK is, if you like a private agreement, that our health authorities will say, well, we're only going to put aside X million pounds to pay for this drug. That's going to pay for, say, 50 patients, you know, or whatever, depending on how much you charge for it. And then there's a deal, and we sometimes never know what the price is, but my guess it'll be somewhere between £20,000 and £30,000 a year is what it will come out at. I don't know whether Germany, what you will do there.
Yeah, it's I guess 7,000 per month, so almost 85,000 euros in Austria and Germany, and they will reduce it to, I guess, almost the half by next year, but the initial price is quite high.
60,000 is the figure that I was told per year.
Yeah.
Euros.
I think, you know, clearly these numbers bear no relation to the drug cost. And I think we have a very clear understanding of how much the whole development, you know, the 10, 15-year development pathway cost. Yeah, I think I think it's hard to defend these prices, but it's hard to know what to say. It's the world that we live in. I think another dysfunctionality in the whole healthcare system is there's no competition. You know, we've had eculizumab for whatever 15 years with no competition, charging vast amounts of money. Yet There are lots of other complement inhibitors around, but nobody has been encouraged to challenge them and launch one at a half the price. Now we have InflaRx, who have got vilobelimab, which is a monoclonal anti-C5a antibody with very similar results in their phase 2 to the Avacopan phase 2s. And so if they were to take that through to a phase 3, it would probably work the same as Avacopan, but will they do that? I don't know.
Yeah, I think then it's, of course, patient preference, right? To either take tablets or have a subcutaneous infusion. That's clearly would be an advantage for us. So my last point is another new drug which has or is about to revolutionize probably lupus nephritis, obinutuzumab. Can you say something about efficacy and the prospect of obinutuzumab in AAV?
So this is an anti-CD20 monoclonal, so-called type 2, which binds to a different extracellular antigen, CD20, to rituximab, and has greatly increased antibody-dependent cellular cytotoxicity compared to rituximab. So in non-Hodgkin's lymphoma and chronic lymphocytic leukemia, it produces an order of magnitude better clearance of residual disease activity in head-to-head studies to rituximab. So that was the original license. And really Genentech, who developed obinutuzumab, are really just looking for other indications. And for some time now, people have been using other CD20s in patients allergic to rituximab or in whom rituximab has not depleted B cells. And there's data with ofatumumab and some data with obinutuzumab. So I have no doubt that obinutuzumab will work. And one of the questions that we're interested in is whether it will be significantly better than rituximab for patients with granulomatous disease. And in the early rituximab days, there were a number of reports, for example, from Wolfgang Gross's group, that rituximab is not particularly effective for retroorbital disease, granulomatous disease. I think it is. It just takes a long time, and you often have to give more doses. But we know from tissue biopsies that rituximab does not deplete tissue B cells particularly well, and we think that's part of the reason why the granulomatous disease is harder to treat. So I think an interesting hypothesis is whether OB will be better than that. I think the other interesting hypothesis is whether the duration of response will be much longer, partly possibly because you get better tissue depletion. Because if you're going to get a 2-year response, say, rather than, for example, a 6-month response to rituximab, and you only have to give the B cell depletion every 2 years, you might then have an interesting balance on the safety side of giving a more potent depleter but less frequently versus rituximab, it's a less potent depleter but more frequently. We don't know how that will play out. But I have concerns about the immunodeficiency because of our rituximab experience, and upfront OB is going to be worse.
Thanks so much. So this was really an honor and pleasure for us to discuss all these important studies with a man who did all these studies and with 2 of his collaborators. So thanks again for this academic hour, but surely much more thanks for all the academic work you did in the last years and that helped so many patients to lead a better life. Have a nice evening and hopefully meeting you one day again. Thank you.
Thank you very much. Bye-bye.